I remember when I got my first NIH grant, I called the grant manager at the NIH to be sure there wasn't a mistake. Did I really get this grant? And she said to me, I don't know who she was. She said, Dr. Kaufman, does it have your name on the application? I said, yes. She's like, does it say you've been funded? I said, yes. She said, why would you think that's a mistake? Why do women think that? And no man has ever called me.
I had the incredible privilege of speaking with Dr. Fran Kaufman, a legendary pediatric endocrinologist with 45 years of experience. Dr. Kaufman's career is truly extraordinary. She has led groundbreaking research, trained countless residents and fellows, and worked in industry as the chief medical officer for Medtronic and now Senseonics, all while continuing to care for her patients in her clinical practice. She's also been a leader in diabetes camps and traveled the world delivering endocrinology care, often bringing her family along with her as a mother in medicine. Dr. Kaufman's insights into endocrinology and medicine as a whole are unparalleled. In this episode, we focus on how the field has evolved over her career and explored the feminization of endocrinology and its implications for our specialty. Today, more than 70% of endocrinology fellows are women. While this might suggest the field has become more accommodating for women, the reality tells a different story. Applications for endocrinology fellowships are declining for both men and women, though the drop is more pronounced among male physicians. Endocrinology now ranks as the lowest paying specialty in medicine, according to Medscape's 2024 Physician Salary Report. Despite similar training durations to high-earning specialties like cardiology or orthopedics and longer training than many better compensated fields, endocrinologists face significant financial disadvantages. This compensation struggle has created a critical shortage of endocrinologists, with only about 7,000 practicing endocrinologists in the U.S. compared to the 38 million people living with diabetes, not to mention those with other endocrine disorders. Even if every endocrinologist saw 20 diabetes patients daily, 52 weeks a year without a single day off, we still wouldn't meet the demand. Dr. Elaine Pelly, an endocrinologist, published a thought-provoking article in the Journal of Clinical Endocrinology and Metabolism on the feminization of endocrinology and its repercussions. She highlights the challenges women in the field face: the gender pay gap, which persists even in medicine, occupational segregation, where female-dominated specialties tend to have lower wages across all fields, the motherhood penalty, where mothers are perceived as less committed and competent compared to non-mothers and are less likely to be promoted. This contrasts sharply with the fatherhood bonus, where fathers are rewarded with higher pay, promotions, and greater flexibility. Endocrinologists are already an endangered species, and the feminization of the field raises additional concerns. Without endocrinologists, patient care suffers, especially in the midst of a global pandemic of diabetes. In this episode, Dr. Kaufman reflects on her remarkable journey and the seismic shifts she's witnessed in endocrinology and healthcare. Together, we discuss the challenges and opportunities that come with the feminization of our specialty and brainstorm potential solutions to make endocrinology more appealing to trainees. Thank you for tuning in. I hope you enjoy the conversation. If you're looking for links to any of the topics we cover, you'll find them in the show notes. Dr. Kaufman, I am so excited to have you on our show to talk about the feminization of endocrinology and just give us a historical breakdown of what you've experienced in this field. So thank you so much for being here with me today.
Well, thanks for this opportunity. So I've been doing endocrinology about 45 years, which is a long time. Seen a lot of advancements. It's been really exciting to be in the field for this duration. When I first started medical school, it was about 10% women. And then I wanted to be a surgeon, but didn't really like it once I got in the OR. And then, got enamored with a long-term relationship with patients, could see them over time, and also decided to do it from a pediatric perspective rather than from internal medicine. So, of course, there were more women in pediatrics and more women in pediatric endocrinology as a result, but got very involved in, what was going on in the general landscape. And there were the minority of, individuals who were women, fewer on the internal medicine side, again, than the pediatric side, but it was still a predominantly male field, as was all of medicine. Better than surgery, obviously, but still male dominated, and particularly white male dominated. And most of the mentors and, luminaries in the field had been practicing for decades, had made major contributions. I'm not by any means diminishing what these, incredible individuals did during their career. And at the same time, there were very little provisions around pregnancy, around anything that kind of related to being a woman. When I got pregnant as a resident, it was one of the first, pregnancies that had occurred, and they were unclear what to do. I mean, they asked me, so who's going to take your call if you don't feel well? And I said, well, what happens if I didn't feel well and I'm not pregnant? Who's going to take my call? So there was a lot of pushback around many aspects of what are unique, to being women. And then, of course, once you had a child, what about part-time possibilities or job sharing or any of those aspects? And we've come a long way. We're not all the way there yet, but we've certainly made strides, and maybe because we're the majority of people, or close to the majority of people entering medical school, and in specialties like endocrinology. However, I still think there's a bit of a glass ceiling. It's still a little bit harder when trying to figure out how do I fit in children, and the fact that even in a relatively equal or marriage of equality, women still end up doing more, childcare, more concern around housekeeping and groceries and laundry and things like that. So it's been a struggle. We've made a lot of strides, but we're not completely where we should be either.
Yeah, absolutely. And I love having your perspective, because when I came into endocrinology, it looked like it does today. It's 70% of endocrinology fellows are women today. And so hearing that shift in the way the career has looked is really interesting and fascinating. I'm curious, how did it feel to be a woman in such a male-dominated environment?
Well, I think it felt differently depending on who you were. I was involved very early on in a little research project at the University of Southern California where I was on faculty. And they asked a bunch of questions about, have you been discriminated against? Have you been, misogyny? I mean, all those kind of things. And I didn't really see it until I started examining, some of the push downs that women could receive, and, aspects in our career, again, because it was still male dominated. And I just didn't let it bother me. So I had grown up only with brothers and male cousins. So I was used to just ignoring what was ridiculous. And not every woman, had that same kind of outlook or experience. But there was, a lot of, I just remember when I was an intern, I was part of the first all-women's team we had at Children's Hospital Los Angeles. The guys would open the door and kind of, say things, to kind of diminish the fact that we could do a job as 4 women, as equal to 4 men. Those days are over, fortunately, and obviously we have certainly proven ourselves, whether we needed to or not, is to our contributions and our capabilities. But it was a bit of a struggle. I mean, you had to, I think I worked harder in some ways than some of the men I was not competing with, but, at the same level, and competing in grants, competing, even in patient care in a city as big as Los Angeles, that there was, some innate, need to prove yourself.
It's so interesting. Like, I think women have this experience of, I need to not only do as much work, but more work than perhaps my male counterparts, and show up more to receive equal or perhaps even lesser recognition for that work. And when you were starting out, it was so, I guess, unusual to see a woman in medicine that I imagine you probably felt that pressure even more so than we do now. Would you say that's true?
Absolutely. So I remember, well, probably 2 decades ago, I had the opportunity to look at my own file inside my own institution. And my intern interview started out for a woman, comma, so, already diminished compared to what you'd expect from a man. So, I do think there was, some issues, maybe not every day. I mean, you worked equally. People certainly appreciated, all that everybody did. And it was a tremendous camaraderie, right? To be able to, to be together as interns and residents and young faculty and older faculty. And I, truly value the relationships I had with everybody. But it was a little bit of a struggle. I worked part-time for a while, mainly because there were tremendous budget constraints in my hospital, that they could only afford somebody part-time, and, had to negotiate that 50% working effort shouldn't be an equivalent year for my tenure. They said, well, you're here a year, you should, that should count as a year. I said, well, I'm only here 50% of the time. How can that count as a full year? So there were all kinds of little pitfalls that you didn't know until you were deep inside one of them. But, with rationale and, I think just achievement, I was able to get that kind of balance that I think, I needed personally. But it was only because there were tremendous budget cuts.
So when you first finished your training, did you work clinically? I know that you have done both as far as industry and clinically. What was your career trajectory in endocrinology?
So from 1978 to 2009, I was a faculty member at Children's Hospital Los Angeles, and USC was my faculty appointment. I had research grants. I was NIH funded my entire career. And in those days, maybe I was doing all three components. I was teaching, I was doing research. I had a basic lab for a while and a lot of clinical research, as well as seeing patients. And then I became head of our division of pediatric endocrinology at Children's Hospital and was doing administrative work as well. But at that point, obviously, I was full-time. I was only part-time for 2 years.
And then after 2009, what did you?
Then I went to become the chief medical officer at Medtronic Diabetes for 10 years, mainly to be involved with the finalization and the launch of the first automated insulin delivery device, the 670. And was there till 2019, and now I'm the chief medical officer at Senseonics. But I have still seen patients all along. So matter of fact, I'm in my clinic today. So
I think that, first of all, can we just sit in appreciation of the grandeur of that technological advancement of the hybrid closed loop system. Like I trained on the cusp of, when I was in my training, we didn't use it, but it came out kind of in my first year of practice, and the profound impact that it has had on our patients' lives is just, it's astounding. And it amazes me that I know the research has gone on for a very long time, but in such a short window of time, technology has advanced diabetes care just so much. And how do you feel being on the kind of forefront of that?
I was in the right place at the right time. It was, I had always done clinical research in diabetes technology as well and diabetes advancements. I remember when Humalog came out, or actually Humulin, even human insulin. We were involved in some of that early research, early pump research, sensor research. And it was always exciting to be part of large consortiums of other investigators with the ability to have a big enough patient population to contribute to a number of these efforts. But personally, I was kind of recruited to Medtronic by the then president of the diabetes division, a man named Chris O'Connell, who wanted me to be the chief medical officer to really kind of help tie together all the aspects of, first we have threshold suspend and then predictive threshold suspend. And then we got to, the hybrid closed loop. So it was just a phenomenal experience for me. It was a little hard leaving academics at the beginning. I had always viewed myself as an academic. But I got over it, and I've really enjoyed this ability to be kind of on both sides of the world. And although I'm, kind of in my mid 70s at this point, I'm not going to quit working, and who knows, maybe I'll even have another career opportunity.
Yeah, I love that you mentioned that you still practice clinically, because I think as we decide on alternative opportunities that may be non-clinical, I think it's very difficult. And I actually am a huge believer in staying at least clinical part-time, because I think that it makes us relevant and it enables us to really be in touch with our patients and what's going on the ground. I think it's very difficult to not lose touch, and probably not lose touch quickly with what's going on with our patients if we don't have some clinical time. So I love that you're doing that. Is that why you choose to stay clinical, or what's your reasoning?
I mean, certainly that's part of it. I think it's an opportunity to, come to work for a day and actually interact, solve problems, work collaboratively. Whereas, if you just do research, and I did a tremendous amount of research in my career, it's really delayed gratification. I mean, some of those projects last forever, right? If you just do administration, it's at a much different level, the interactions. So I kind of feel like when I come to clinic, it's almost like a fix. I walk out, even however challenging it might be, kind of feeling that I contributed today in this very specific way. It feels good.
Yeah.
And of course, I just saw a patient. He's 12. I've seen him since he was 2. I know everything about him. His family knows everything about me. I mean, it's a real, amazing partnership.
I love that. We've talked a lot today about relationships and how the relationship between a doctor and patient has to be a give and take. And so I love that you said they know everything about me too, because I don't know if it was like this in your medical training, but in mine, and I finished medical school in 2012, there was this idea that you should intentionally separate yourself from the patient. And it wasn't, it was kind of a professional distance. And of course, yes, there are lines that we shouldn't cross. But as I've gone into practice, I've recognized that I have to give a little to get a lot from them. And that relationship actually is very healing for patients, of course, but also for us to have a human experience as a physician. How do you feel about that?
Oh, when I started, I mean, you were Dr. Kaufman in a long white coat, and you never said anything about yourself at all. And I, right out of my training, refused to wear a white coat. It was the beginning of that movement. And I asked my patients to call me Fran. And I remember my mentor, who, I still adore, and, just from a different world, the world right before I was there. I mean, she said, no, none of your patients are going to respect you. You can't do this. It's ridiculous. I mean, they can't call you by your first name. And, I just didn't agree with that. So, I've been Fran to all of them. The kids call me Fran. And, if they want to call me Dr. Fran, I think that's more contrived than just calling me Fran. Everybody's got my home phone number, or I don't have a home phone number, I guess, my cell. And, obviously this is very individual, and it is also how my practice was set up. I wasn't, seeing a patient every 15 minutes. I had much more luxury than that. But, my concept is if you need me, just find me. It's easier to be found than to unwind you talking to somebody else who doesn't know what's going on, and, or going to an ER, and, them getting, you're hypoglycemic and they're still going to get a CT, even you don't need one. So that's, just how I chose to practice. And, I think, I've hardly ever lost a patient, to saying, oh, I don't like her style. It's more, they really like my style. I mean, so my patients now are a little bit older than perhaps they should be for a pediatric endocrinologist. The patient before this last one flew in from New York to see me because, she's just not able to find somebody who she thinks can relate to her.
Yeah, I think that relatability is so important. And I think our patients are craving that, especially now that, like you mentioned, a lot of visits are 15 minutes and there are these big barriers, and trying to get in touch with your doctor if you have a question, if they are part of a big hospital system, well, good luck, because I can't even find them and I'm a doctor. There's no longer that number to push. If you're a physician, push 2. I've tried calling several clinics at some of our large hospital systems here in Houston. It's no longer an option. And so I think that patients need that, especially people living with diabetes. They are living with it every second of every minute of every day, and they need support. So I'm so grateful that people like you exist to take care of our kiddos. I would love to hear sort of, and this is kind of a big question, so we can break it apart, but I would love to hear how you've seen endocrinology as a field change over the last few decades. I know it's a big question, so I can ask a more specific one if that's too much, but I'll let you start.
Well, I mean, I could take hunks of it. I think maybe the biggest change has been hospitalists. I followed my patient through their hospital stay. Even when maybe you're not on call, you'd never think of leaving the hospital for that day without even going by and saying hi. You never think about not reaching out to your coworker to find out what's going on with your own patient. And, I started medicine. There was no word called hospitalist. It was called interns and residents, actually, is what I think, or maybe chief residents. And then one day, I don't know how many are there, 100,000 of them in the country. Maybe it's better. I don't know. And certainly the whole shift. So I do view myself as a dying species of how I practice, and, my entire career. The hospital isn't like that anymore. Practices aren't like that anymore. The expectations, EMR, I mean, you name it. It's all changed. Probably for the better in a lot of ways, in that there's more efficiency in looking in the EMR, or it's easier to get the right prescription, perhaps, although I searched all morning for Afrezza for somebody and realized it's not even in our EMR. So, I mean, the trends are bigger than all of us. I don't think there's an endocrinologist left in Los Angeles who isn't part of a big system. Either Cedars or UCLA or USC or Providence or, a couple systems, but the private practice of medicine is gone. The what's reimbursable, how your day is divided up, what the expectations are, how you interact with patients. I mean, it's all changed. And I just have to believe in the long run, it's for the better. Although I do miss the days of when I first started my career. I mean, we had enough time to meet after every clinic we had. And we talk about every patient somebody saw. And, on Diabetes Day, we talk about every patient before somebody saw them. We had 300 patients with diabetes. Now we have 3,000. When I came back part-time after my fellowship and after my second child, we were 2.5 doctors. Now we're 22. So, I mean, the population change, the incidence of diabetes change. I mean, all of this is just fundamentally, altered the core tenets of the practice of medicine.
So you mentioned something that I share a sentiment with, and it's extreme ownership. Extreme ownership, that is my patient. And my worry is that in this system where we're so separated from our patients, I have a direct care practice, so my practice is probably more similar to your old practice than the traditional settings that you're describing today. But that my fear is that with all the separation between the doctor and their patient, that we have lost that extreme ownership, that is my patient. And I'll tell you a story that was one of the events that led me to seek a different practice model. And I was in private practice, employed, and an MA said, "Can I add this patient onto your schedule today?" And she said, "It'll be really quick. It's just a pre-diabetes." And I was in a rush, and I didn't really think. I just said, "Fine, whatever. Add the patient to my schedule." So I go in, and it was an 18-year-old woman with prediabetes and PCOS, struggling with obesity. And an hour later, I walk out of the office visit, and I said, "Thank you for adding that patient to my schedule. She really needed my help. But don't you ever tell me that it's just anything, because this is my patient, and I have the incredible privilege to change the trajectory of her life and her metabolic health. And it's never just anything." And she was very taken aback, but I think it taught her a lot about me. But more importantly, it taught me a lot about me and how I was going to struggle in a system where I only had 5 to 10 minutes with my patients. And in order for me to, I liked that about myself. I liked that I loved my patient so much. And I liked that I believed that I had this crazy confidence that my actions could actually change something. I worry that in a setting where many doctors are kind of have that passion beaten out of them in a productivity-based setting, that we're losing that extreme ownership that I think is valuable to both physicians and patients. That's it for part 1 of this conversation. If you're enjoying the discussion, be sure to tune in for part 2, where we'll continue the conversation and go even deeper. Make sure you're subscribed so you don't miss it.